Welcome to the deep dive. Today, we're really getting into a crucial area for anyone in nursing the gastrointestinal system.
Yep, the GI system.
We're pulling our knowledge straight from Chapter 45 of the Saunders Comprehensive Review for the NCLEX-PN Examination, 7th edition. Think of this as, your fast track to understanding the GI tract from a nursing viewpoint.
Absolutely. And this chapter really focuses on, the absolute priorities in nursing.
Yeah.
How the body gets rid of waste, elimination.
Right.
And how it takes in and uses nutrients. So, nutrition. These two, elimination and nutrition, they're basically the foundation for our whole discussion today.
Exactly. So our mission here for you listening is to pull out all that essential knowledge packed into this chapter. We're talking about how the GI system actually works, what common problems pop up, how we figure out what's going on with all the different tests, and really importantly, what nurses actually do to care for patients with GI issues.
Yeah, the practical side.
Consider this your shortcut to feeling, more confident about this whole system.
Okay.
Okay, let's dive right in.
Let's do it. So, the chapter intro, it doesn't list out every single function, but it sets the stage. Basically, the GI system takes in food and liquid, breaks it down.
The digestion part.
Right. Breaks it into nutrients the body can use, absorbs them, and then gets rid of the waste that's left over. It all ties back to those core concepts, nutrition and elimination.
Makes total sense, the whole input-output cycle. Now, when things aren't running smoothly in the GI tract, there are loads of ways to, investigate. The chapter covers a whole battery of diagnostic tests.
A lot of them.
Let's start at the top, literally with the upper GI endoscopy, or esophagogastroduodenoscopy. That's a mouthful.
It really is. But basically, it's a way to get a direct look inside the upper part of the digestive system. A doctor uses a thin, flexible tube with a tiny camera with the endoscope
Okay.
to see the lining of the esophagus, the tube from your mouth.
Yep.
The stomach itself, and the duodenum, which is just the first bit of the small intestine.
Okay, so if someone's having this done, what's the rundown? Before, during, after?
Okay, so before, the big thing is an empty stomach. That means NPO, nothing by mouth, for about 6 to 8 hours.
Got it. 6 to 8 hours.
Yep. To make it more comfortable, they might get a local anesthetic spray or something to gargle to numb the throat. And often, conscious sedation is used, maybe with something like midazolam, to help them relax.
Keeps them comfortable.
Exactly. They might also get meds to reduce secretions or relax the muscles down there. And during the procedure itself, the patient usually lies on their left side.
Left side specifically. Why is that?
It mostly has to do with gravity and anatomy. It helps saliva drain and just makes it easier to guide the scope smoothly through the tract.
Oh, makes sense.
And during the whole thing, the team keeps a close eye on breathing and oxygen levels, usually with a pulse oximeter. And standard procedure, emergency equipment is always right there, just in case.
Good to know. And once the scope's out, what happens then?
Afterwards, they stay NPO until that gag reflex comes back. That's super important to prevent aspiration, food or liquid going down the wrong pipe.
Right. Don't want that.
Definitely not. Vital signs are monitored closely, blood pressure, heart rate, and nurses watch for any signs of perforation, which is like a tear. It's rare, but serious.
Okay. Next up, capsule endoscopy. This sounds like something from a sci-fi movie.
It kind of does, doesn't
Yeah.
it? So instead of the tube, the patient actually swallows a small capsule about the size of a big vitamin.
Swallows a camera.
Pretty much. It has a tiny wireless camera inside. It just travels naturally through the whole digestive tract. Its main job is to snap pictures of the small intestine lining, which can be hard to see otherwise. Great for finding hidden bleeding or changes.
Wow. How does it send the pictures back? Does it have Wi-Fi?
Sort of. It's pretty neat.
Yes.
As it tumbles along, it takes thousands of pictures and wirelessly sends them to a little recording device the patient wears on a belt.
Okay.
That box stores all the images. So the patient usually comes in the morning, swallows the capsule, gets the belt put on, and then they can pretty much go about their day.
Really? Just a normal day?
Yeah, mostly. Then they come back later, the images get downloaded to a computer, and the doctor reviews them. The capsule itself, it just passes naturally in a bowel movement later on.
That is incredible technology. Okay, moving on to tests, focusing just on the esophagus. First, the Bernstein test. What's the goal here?
The Bernstein test is specifically trying to figure out if chest pain someone's feeling is actually caused by acid reflux stomach acid splashing back up into the esophagus.
Okay, and how do they test that?
Well, they gently put a dilute hydrochloric acid solution into the esophagus through a small tube. But first, they put in saline, just salt water, as a control.
To compare.
Exactly. If the patient feels that familiar chest pain with the acid, but not the saline. It's a pretty strong sign their pain is reflux-related acid irritation.
Interesting way to pinpoint it. Next is esophageal manometry. What info does this one give us?
Manometry measures pressures inside the esophagus. It's really about checking how well the esophageal muscles are working. Yeah, like the sphincters, those muscular rings top and bottom, and the peristalsis, those coordinated waves that push food down.
Gotcha. How do they measure those pressures?
They insert thin, flexible tubes, called catheters, usually through the nose down into the esophagus. These are hooked up to a machine that records the pressure changes as the patient swallows, maybe sips of water.
Okay.
It helps spot problems of muscle coordination or strength.
And then there's ambulatory pH monitoring. How's this different from the Bernstein test, which also looked at acid?
Good question. Ambulatory pH monitoring gives a much longer picture of acid reflux. It tracks how often and for how long acid refluxes into the esophagus over typically a 24-hour period.
So Bernstein is like a snapshot, pH monitoring is like a movie.
That's a great way to put it, yeah.
So how does that work for the patient over 24 hours?
A really thin probe is placed just above the lower esophageal sphincter, the LES. It's connected to a small, portable recorder the patient wears, maybe on a belt or strap. It just sits there measuring the pH or acidity constantly. After 24 hours, they download the data, and a computer analysis shows exactly when the reflux happened. Prep-wise, they need to fast for at least 12 hours beforehand.
And after?
After it's done, they can usually just go back to their normal diet.
Makes sense to track it over time. Then we have gastric analysis. What can we learn by actually looking at stomach contents?
Gastric analysis measures the amount of hydrochloric acid and pepsin, that key digestive enzyme in the stomach. It helps diagnose conditions where there's maybe too much or too little acid being produced.
How do they get the sample?
They insert an NG tube, nasogastric tube, through the nose, down into the stomach. Then they gently suction out or aspirate some of the stomach contents through the tube.
Okay. Any special prep?
Yep, NPO for at least 12 hours before. Also need to hold certain meds like anticholinergics for 24 hours and no smoking the morning of the test because those things can affect stomach secretions. During the test, they might get a small injection, maybe histamine or penigastrin, under the skin to stimulate gastric secretions. Just a heads up for the patient, that shot can sometimes cause a temporary flushed feeling.
Good to know. Okay, we've covered the upper parts. Let's move down to the large intestine and talk about fiber optic colonoscopy. Pretty common procedure.
Very common. A colonoscopy lets the doctor see the entire length of the large intestine, all the way from the rectum up to the cecum, using a long, flexible scope with a camera.
And the prep for this, I know bowel prep is usually the main event for the patient.
Oh, absolutely. A clean colon is crucial for a clear view. So thorough bowel cleansing is essential, using strong laxatives prescribed by the doctor.
Right, the prep.
Exactly. Patients are usually on a clear liquid diet the day before, and they need to avoid red, orange, or purple liquids because those can look like blood.
Ah, okay. Good tip.
And it's really important they talk to their doctor about all their meds, especially blood thinners like aspirin, anticoagulants, antiplatelets. Those might need to be adjusted before the procedure.
To reduce bleeding risk.
Yep. And just like the upper endoscopy, they'll be NPO for 6 to 8 hours before and get conscious sedation, often midazolam, to relax.
And during the procedure and right after, what's happening?
During the colonoscopy, they usually lie on their left side with knees pulled up, though the position might change a bit to help the scope move along. Heart rate, breathing, oxygen levels, all continuously monitored.
Okay.
Afterwards, the nurses monitor for passing gas flatus, which shows the bowels waking up. They listen for bowel sounds. And crucially, watch for any rectal bleeding, blurting, or significant pain. Patients get told to report any bleeding after they go home.
Got it. The chapter also mentions sigmoidoscopy. How's that different from a full colonoscopy?
A sigmoidoscopy is similar, uses a flexible scope, but it's less extensive. It only looks at the lower part of the large intestine, the sigmoid colon and the rectum.
So a more limited view.
Exactly. And because it's a smaller area, the bowel prep is usually not quite as intense as for a full colonoscopy. It's often used for screening specific issues in that lower section.
Okay. Let's switch gears to laparoscopy. This sounds more surgical.
It is a surgical technique. Laparoscopy lets doctors look directly at the organs inside the abdomen using a thin telescope-like instrument, the laparoscope.
How does it get in?
Through one or more small incisions in the abdominal wall. It's used for diagnosis, and the surgeon can also take biopsies, small tissue samples during the procedure.
Right. And then we have ERCP, endoscopic retrograde cholangiopancreatography, another long one. What does ERCP let doctors see?
ERCP is pretty specialized. It's used to examine the hepatobiliary system, so the liver, gallbladder, bile ducts, and pancreatic ducts.
How do they get there?
They guide an endoscope down through the esophagus and stomach to the duodenum. Then a smaller tube goes through the scope, and they inject contrast dye into the bile and pancreatic ducts. X-rays are taken then to see those ducts. Because of the path, the patient might need to be moved into different positions during the procedure.
Okay. What's the prep and aftercare for ERCP?
Similar MPO for 6 to 8 hours before, and it's really important to ask about allergies to contrast dye since that's used.
Good point.
Sedation is given. Afterwards, it's close monitoring of vital signs, checking for the gag reflex return before eating or drinking, and watching for any signs of complications like perforation or infection.
Next is percutaneous transhepatic cholangiography. How's this different from ERCP for looking at bile ducts?
PTC, for short, is another way to see the bile ducts, but it uses a different route. Instead of an endoscope down the throat, a thin needle goes through the skin, percutaneously, directly into the bile ducts inside the liver.
Through the skin?
Yep. Then they inject the contrast dye and take X-rays.
So a more direct puncture into the liver area?
Yes, it bypasses the upper GI tract. Prep is similar, NPO 6 to 8 hours, check for contrast, allergies, sedation. But afterwards, because it's more invasive, monitoring for bleeding and any respiratory issues is really key.
We're covering so much ground. Let's shift to something non-invasive, abdominal ultrasound.
Ultrasound uses sound waves to create images of the abdominal organs. It's very safe, generally no risks. The main thing is being NPO for at least 8 hours before. This just helps reduce gas in the bowel, which can kind of obscure the images.
Make them clearer.
Exactly. And after. No specific care needed. Pretty straightforward.
Now, paracentesis. I usually think of this with patients who have a lot of fluid buildup in their belly, like ascites.
That's exactly when it's done. Paracentesis is removing fluid from the peritoneal cavity, that space around the abdominal organs, using a needle inserted to the abdominal wall.
What are the key nursing responsibilities for this?
Okay, several important things. First, ensuring informed consent. It is invasive. Get baseline vital signs, including weight. Help the patient empty their bladder right before.
Why the bladder?
To avoid accidentally puncturing it with the needle during insertion. The patient is usually positioned upright, maybe sitting on the edge of the bed or in a high Fowler's position.
Okay.
During the procedure, the nurse assists the doctor, keeps monitoring vital signs, and provides support. Afterwards, apply a dressing. Keep monitoring vitals, especially blood pressure and pulse.
Why especially those?
Because removing a large volume of fluid quickly can cause blood pressure to drop. Vasodilation can happen.
Okay. Makes sense.
The patient usually needs some bed rest. You have to measure the fluid removed, send samples to the lab, document everything, how the patient tolerated it, what the fluid looked like, how much, and watch closely for complications.
Like what?
Things like hypovolemia, low blood volume, electrolyte shifts, changes in mental status, encephalopathy, maybe even blood in the urine. Any of those, report to the RN right away. Oh, and reweigh the patient and measure their abdominal girth afterwards to compare with the baseline.
Lots to track there. Next, liver biopsy. Sounds like a key diagnostic tool for liver issues.
It definitely is. A needle goes through the abdominal wall, often guided by ultrasound, to get a small sample of liver tissue for examination under a microscope.
What's critical before this procedure?
Beforehand, you must check coagulation tests, PT, PTT, platelet count.
Yeah.
The liver is very vascular, so bleeding risk is a major concern. A sedative might be given. Positioning is usually flat on the back, or sometimes left side lying, to expose that right upper abdomen where the liver sits.
And after the biopsy, what's the focus?
Post-biopsy, it's all about monitoring. Vital signs very closely. Checking the biopsy site for bleeding or bruising, watching for signs of peritonitis, though our text doesn't detail those. Bed rest for several hours is standard.
And positioning.
Key intervention. Position the patient on the right side with a small pillow tucked under their lower ribs for about 2 hours. This puts direct pressure on the biopsy site.
To help stop potential bleeding.
Exactly. Also advise them to avoid coughing, straining, heavy lifting, or strenuous exercise for about a week. And this brings us back to that critical thinking point.
Yes, the patient with the abnormal clotting labs before the liver biopsy. The prothrombin time was 35 seconds.
Way too long. Normal is around 11 to 12.5.
And the platelet count was 100,000.
Also quite low. Normal is usually 150,000 to 400,000. So both of those scream increased bleeding risk.
So the nursing action.
Immediately notify the RN and the primary healthcare provider before the biopsy happens. The risk is just too high without addressing it. The procedure might need to be delayed or special precautions taken.
Absolutely crucial safety point. Okay, let's move to something nurses handle frequently. Stool specimens.
Stool samples can tell us a lot. We can look at consistency, color, check for occult blood, the hidden blood.
Right.
Look for things like fecal urobilinogen, fat, nitrogen, parasites, bacteria, even undigested food.
What are the important points for collecting these samples?
For random samples, get them to the lab promptly. If it's a timed collection, like 24, 72 hours, the samples usually need to be refrigerated.
Okay.
And always check if there are specific diet or medication restrictions for the particular test being done. Agency guidelines are key here.
Got it. Then there's the urea breath test. This one's for detecting a specific bug, right?
Yes, the urea breath test is specifically for detecting H. pylori, Helicobacter pylori, that bacteria is strongly linked to peptic ulcers.
How does a breath test work for a stomach bacteria? Sounds odd.
It's clever. The patient swallows a capsule containing urea, but it's urea made with a special labeled carbon atom.
Okay.
If H. pylori is present in the stomach, its enzymes break down this urea, releasing the labeled carbon. This carbon gets absorbed, travels in the blood, and is eventually exhaled.
So you test the breath for that labeled carbon.
Exactly. They collect a breath sample about 10-20 minutes after swallowing the capsule. If the labeled carbon is there, it means H. pylori is present. Important note, though, lots of meds interfere with this test.
Like what?
Antibiotics, bismuth subsalicylate like Pepto-Bismol need to be stopped for about a month. Sucralfate and PPIs like omeprazole for a week. Even H2 blockers like famotidine or ranitidine for 24 hours.
Good to know. Lots of potential interactions.
Definitely. And you can also detect H. pylori through blood tests looking for antibodies.
Okay. Lastly, for diagnostics, liver and pancreas lab studies. These blood tests must give key clues about organ function.
Absolutely. Liver enzymes like ALP, AST, ALT, they often go up with liver damage or bile duct blockage. The chapter gives normal ranges.
We talked about prothrombin time, PT, already.
Right. Prolonged PT points to liver damage since the liver makes clotting factors. Serum ammonia levels check the liver's ability to process protein byproducts. High levels are bad. Cholesterol can be affected too, might increase with pancreatitis or biliary obstruction. Bilirubin levels, total, direct, indirect, they usually rise with liver damage or bile duct issues. Again, ranges are provided.
What about the pancreas-specific ones?
Amylase and lipase are the key ones. They're usually way up in acute pancreatitis. The text doesn't give ranges here, but that elevation's classic. And CA1929 is mentioned as a tumor marker that can be elevated in pancreatic cancer.
Wow, that was a fantastic tour through GI diagnostics. Now let's switch gears and talk about the common problems, the disorders, and how they're managed. Starting with GER, gastroesophageal reflux disease.
GERD.
Yeah.
Very common. It's when stomach contents, including acid, flow back up into the esophagus because that lower esophageal sphincter, the LES, isn't working quite right.
What are the classic symptoms someone might complain about?
Things like epigastric pain, upper middle abdomen, pain, heartburn, that burning feeling, indigestion or dyspepsia, nausea, regurgitation bringing food back up, sometimes difficulty swallowing, dysphagia, or even making extra saliva, hypersalivation.
And how do we help patients manage GERD? What advice does nursing provide?
It's usually a mix of lifestyle changes and meds. Lifestyle-wise, avoid trigger foods that weaken the LES or irritate the esophagus.
Like what kind of foods?
Things like peppermint, chocolate, coffee, fried or fatty foods, carbonated drinks, alcohol. Smoking is a big one too.
Okay.
Eating smaller meals, lower fat, higher fiber can help. Avoid eating or drinking for a couple of hours before bed. Loose clothing is better than tight belts. Elevating the head of the bed 68 inches is key for nighttime reflux.
That makes sense.
Also avoid meds that can worsen it if possible. Anticholinergics, NSAIDs, aspirin. And then there's reinforcing how to take prescribed meds. Antacids for neutralizing acid, H2 blockers or PPIs to reduce acid production, maybe prokinetics to help the stomach empty faster.
And if none of that works?
In severe cases, surgery might be an option, like a fundoplication, where they wrap part of the stomach around the esophagus and tighten that sphincter, often done laparoscopically now.
Okay. Moving on to gastritis. What's actually happening with gastritis?
Gastritis is simply inflammation of the stomach lining, the gastric mucosa. It can be acute, sudden onset, usually short-lived or chronic, developing slowly.
What causes it?
Acute can be from contaminated food, overdoing aspirin or NSAIDs, too much alcohol, bile reflux, even radiation. Chronic causes are broader. Ulcers, H. pylori infection, autoimmune issues, diet, meds, ongoing alcohol use, smoking, reflux.
How do nurses intervene for gastritis?
For acute cases, Maybe withhold food fluids initially until symptoms calm down. Then slowly reintroduce ice chips, clear liquids, solids. Keep a close eye out for hemorrhagic gastritis signs like vomiting blood, fast heart rate, low BP.
Right, bleeding is a risk.
Definitely. Yeah. Avoiding irritants, spicy food, caffeine, alcohol, nicotine. Reinforce taking prescribed meds like antibiotics for H. pylori or antacids. And if they develop B12 deficiency from chronic gastritis, they'll need education on B12 injections.
Got it. Now, peptic ulcer disease, PUD. Pretty common, right?
Yes, PUD involves sores or ulcers in the lining of the stomach. Pylorus, duodenum, sometimes esophagus, anywhere exposed to stomach acid. They can go quite deep. The chapter focuses on the most common, gastric ulcers in the stomach and duodenal ulcers, the first part of the small intestine.
Let's break those down. Gastric ulcers first. What are the key points?
Okay, a gastric ulcer is an erosion into the stomach's submucosal layer. Risk factors include stress, smoking, long-term corticosteroids or NSAIDs, alcohol, history of gastritis, family history, and H. pylori infection.
Complications.
Main ones are hemorrhage, bleeding, perforation, a hole through the wall, and pyloric obstruction, blockage at the stomach outlet.
What's the pain feeling?
Often described as gnawing or sharp pain, usually in the upper middle or upper left abdomen, maybe 30-60 minutes after eating. Food often makes gastric ulcer pain worse. Vomiting blood, hematemesis, is more common than blood in the stool, melena.
And nursing care for gastric ulcers?
Focuses on monitoring vitals, watching for bleeding signs. During an active ulcer, small, frequent, bland meals are often recommended. Meds are key. H2 blockers and PPIs to decrease acid, antacids to neutralize it, maybe anticholinergics, less common now. Mucosal protectants like sucralfate before meals to coat the ulcer, and sometimes prostaglandins.
And lifestyle.
Absolutely. Avoid caffeine, alcohol, smoking, all the irritants.
Now, how do duodenal ulcers compare?
Duodenal ulcers are breaks in the lining of the duodenum. Risk factors are very similar. H. pylori, alcohol, smoking, stress, caffeine, aspirin, steroids, NSAIDs. Complications are also similar. Hemorrhage, perforation, obstruction, though obstruction might be slightly less common than with gastric.
What about the pain pattern?
This is a key difference. Duodenal ulcer pain is often a burning feeling in the epigastric area, but it typically occurs later, maybe 1.5 to 3 hours after meals, or even at night, waking the person up.
And food.
Often, food or antacids actually relieve duodenal ulcer pain, unlike gastric ulcers. And with duodenal ulcers, melena, dark tarry stools, is more common than hematemesis, vomiting blood.
Is the nursing care similar?
Yes, the interventions are very similar to gastric ulcers monitoring, dietary adjustments, the same types of medications to reduce acid and protect the lining. And patient education on avoiding irritants is just as crucial.
You mentioned hemorrhage as a serious complication. What are nurses looking for?
Hemorrhage from an ulcer is a big deal. Key signs: vomiting blood, bright red or coffee grounds, melena black, tarry stools, and signs of shock rapid pulse, low BP, dizziness, cool skin.
Immediate action.
Monitor vitals constantly, assess bleeding, get IV access for fluids, monitor hemoglobin hematocrit, be ready for blood transfusions, administer any ordered meds to constrict blood vessels.
The chapter also lists perforation and pyloric obstruction as complications, though not in detail here.
Right. Perforation is when the ulcer eats right through the wall, leaking contents into the abdomen. That's peritonitis, an emergency. Pyloric obstruction is scarring near the stomach outlet that blocks food from leaving the stomach properly.
And sometimes surgery is needed for peptic ulcers. What are the options?
Several surgical possibilities exist, especially if meds fail or complications occur. Total gastrectomy is removal of the whole stomach. Vagotomy cuts the vagus nerve to reduce acid secretion. Pyloroplasty widens the stomach outlet. Partial gastrectomy removes part of the stomach. Billroth, the guy, connects the remainder to the duodenum. Billroth II connects it to the jejunum.
What's the post-op care like after these surgeries?
Post-op, you carefully monitor any NG tube, crucially. Don't irrigate or move it unless specifically ordered. You could mess up the surgical site.
Right. Check drainage.
Yep. Watch for complications. Bleeding, infection, and something called dumping syndrome.
Dumping syndrome.
Yeah, it happens when food, especially sugary stuff, moves too fast from the stomach pouch into the small intestine. Causes symptoms like weakness, dizziness, sweating, fast heart rate.
How do you prevent that?
Avoid sugar, salts, milk, high protein, high fat, low carb diet, small meals, no fluids with meals. Lie down briefly after eating, maybe antispasmodics.
Okay. Anything else post-gastrectomy?
Long-term risk of vitamin B12 deficiency because the stomach part that makes intrinsic factor needed for B12 absorption might be gone. So monitor for that, educate about lifelong B12 injections potentially.
That's a thorough look at ulcers. Let's move to bariatric surgery. Increasingly common.
Definitely. Bariatric surgery aims to help people with morbid obesity lose weight by reducing stomach size or altering digestion,
Yeah.
often done laparoscopically now.
Risks involved.
Yes, higher post-op risks like lung issues, blood clots, even death compared to other surgeries. But the benefit in managing obesity-related diseases like diabetes, hypertension, heart disease, sleep apnea can be huge.
It's not just the surgery, though, is it?
Not at all. It's a massive commitment. Long-term success requires major lifestyle changes, diet, exercise, ongoing weight management. Support systems are key too, like formal groups.
The chapter mentions different types, referring to a figure. Can you briefly touch on the common ones?
Sure. The figure likely shows things like vertical banded gastroplasty. Staples and a band create a small pouch. Gastric banding, adjustable band around upper stomach. Vertical sleeve gastrectomy removes a large part of the stomach, leaving a narrow sleeve. Biliopancreatic diversion with duodenal switch, complex, removes stomach part and reroutes intestine to limit absorption. And Roux-en-Y gastric bypass, small pouch connected directly to small intestine, bypassing much of the stomach duodenum. They work by restricting intake, limiting absorption, or both.
What's the nursing care right after bariatric surgery?
Similar to other abdominal surgeries initially. Once bowel sounds return and they pass gas, clear liquids start very slowly, maybe just 1-ounce cups.
Tiny amounts.
Very tiny, to check tolerance. If that goes well, progress to pureed foods, thin soups, milk after maybe 24-48 hours. Then they stay on liquid pureed for about 6 weeks before slowly moving to nutrient-dense regular food, following a strict plan.
What specific diet teaching do they get?
Key points. Avoid alcohol, high protein, high sugar, high fat foods initially. Eat very slowly, chew thoroughly. Progress food types and amounts only as prescribed. They'll likely need supplements, calcium, iron, multivitamins, B12, because absorption is altered. And they need to know how to spot and report dehydration or signs of a gastric leak, like persistent pain or vomiting.
Got it. Let's switch to hiatal hernia. What exactly is that?
A hiatal hernia is when part of the stomach pushes up through the diaphragm, that muscle separating the chest and abdomen into the chest cavity. It goes through the opening, the hiatus, where the esophagus normally passes.
What causes it?
Often weakening of the diaphragm muscles. Things that increase abdominal pressure can aggravate pregnancy, ascites fluid, obesity, tumors, even heavy lifting.
Can it cause serious problems?
It can. Complications include ulcers in the herniated part, bleeding, regurgitation leading to aspiration, strangulation where the blood supply gets cut off, or incarceration where it gets trapped. Those last two are emergencies, can lead to tissue death, peritonitis, even mediastinitis.
What symptoms might someone notice?
Common ones are heartburn, regurgitation or vomiting, difficulty swallowing, feeling uncomfortably full after eating. But many small ones cause no symptoms at all.
Okay. Now, gallbladder issues. Cholecystitis and cholelithiasis. What's the difference?
Cholecystitis is inflammation of the gallbladder. Cholecystitis is the presence of gallstones.
What causes the inflammation? Cholecystitis.
Acute cholecystitis is often caused by a gallstone blocking the cystic duct, the tube leading out of the gallbladder. Bile backs up, pressure builds, inflammation starts. But you can also have a calculous cholecystitis, inflammation without stones, often linked to bacterial infection. Chronic cholecystitis can follow repeated acute attacks.
What symptoms point towards gallbladder problems?
Nausea, vomiting, indigestion, belching, gas. Classic symptom is pain, often in the upper middle abdomen, radiating to the right shoulder blade. Usually starts 2-4 hours after fatty foods, lasts maybe 4-6 hours.
Okay.
Might also have pain right in the upper right quadrant, RUQ, guarding, rigidity, rebound tenderness, maybe a palpable mass there. If bile flow is blocked, look for jaundice, clay-colored stools, dark urine.
How are these typically managed?
During an acute attack, usually MPO to rest the gallbladder, maybe an NG tube for decompression, 4V fluids for hydration electrolytes, pain meds, antispasmodics. For chronic issues or stones causing symptoms, usually advise small, low-fat meals, avoid gassy foods, then prepare for procedures, either non-surgical or surgical.
Surgical options.
Most common is cholecystectomy, removing the gallbladder, often done laparoscopically now, much quicker recovery. If stones are in the common bile duct, might need a colodoc lithotomy to remove them.
What's the post-op care after gallbladder surgery?
Monitor for respiratory complications. Deep breathing can hurt because of the incision location. Encourage coughing, deep breathing, early walking. Teach splinting the abdomen when coughing. Give anti-nausea meds, pain meds. Start MPO, maybe NG suction. Then slowly advance diet from clears to solids as tolerated.
What if they have a T-tube drain?
If a T-tube was placed in the common bile duct, you need to monitor the drainage carefully, amount, color, consistency, odor. Report any sudden big increase. Keep the skin around it clean and dry. Keep the drainage bag below the gallbladder level. Watch for infection signs. Don't irrigate, aspirate, or clamp it unless specifically ordered. Sometimes orders say to clamp it briefly before or after meals to check tolerance as bile starts flowing normally again.
Okay, that covers the gallbladder. Let's move to cirrhosis, a serious chronic liver disease. What's happening to the liver?
Cirrhosis is chronic and progressive. Liver cells die off and get replaced by scar tissue. This scarring messes up the liver's normal structure and function. Common causes are chronic hepatitis C, alcoholism, and fatty liver disease like NAFLD or NASH.
What are the major complications that stem from cirrhosis?
Lots of serious ones. Portal hypertension, high pressure in the portal vein because blood flow through the scarred liver is blocked. This leads to ascites, fluid in the belly. Bleeding esophageal, varices, those fragile enlarged veins in the esophagus that can burst. Coagulation problems because the liver makes clotting factors. Jaundice, portal systemic encephalopathy, brain function affected by toxins like ammonia building up because the damaged liver can't clear them. And hepatorenal syndrome, kidney failure linked to advanced liver disease.
That's a scary list. What signs and symptoms might a nurse see? Cirrhosis affects so many body systems, right?
It really does. Figure 45-2 gives a good overview. Skin changes like jaundice, phytoangiomas, red palms, endocrine issues, immune problems, neurological signs like ascites, that flapping hand tremor, confusion, encephalopathy, lung issues, kidney problems, major fluid electrolyte imbalances like ascites and edema, cardiovascular changes, blood problems like anemia, easy bruising, bleeding, and GI symptoms like abdominal pain, maybe that musty breath odor called fatter hepaticus, and the varices themselves.
How is cirrhosis managed from a nursing perspective?
It's mostly supportive care and preventing complications. Elevate the head of bed for easier breathing if ascites is present. Diet depends. High protein with vitamins might be okay if no ascites, edema, or encephalopathy, but if those are present, restrict sodium and fluids. Diuretics might be used. Paracentesis to drain ascites. Monitor intake output, daily weights, measure abdominal girth carefully.
What if encephalopathy is present or looming?
Then protein might be restricted. Lactulose is often given to help reduce ammonia levels, maybe antibiotics. Crucially, avoid opioids, sedatives, barbiturates, anything toxic to the liver. Absolute alcohol abstinence is essential. Monitor for ascites and fatter hepaticus. If varices bleed, might need NG tube, balloon tamponade, rarely. Blood products, vitamin K, antacids.
Bleeding esophageal varices sound like one of the most immediate life threats with cirrhosis. Why so dangerous?
Extremely dangerous because they can cause massive, rapid blood loss. They're enlarged, weak veins in the esophagus caused by that portal hypertension. Blood backs up, veins swell, walls get thin and fragile, and they can just rupture very easily.
What are the warning signs of variceal bleeding?
Vomiting large amounts of blood, red or coffee grounds, melena. Other signs of cirrhosis like ascites, jaundice, enlarged liver spleen, visible dilated veins on the abdomen, and signs of shock, fast pulse, low BP, cool, clammy skin. The key is sudden, potentially huge hemorrhage.
What are the immediate nursing actions?
Stabilize the patient, control bleeding, monitor vitals constantly, elevate head of bed, check for orthostatic hypotension, listen to lung sounds, give oxygen, monitor level of consciousness, NPO, for fluids to restore volume, monitor H&H, coagulation studies, prepare for blood transfusions, clotting factors, maybe NG2, balloon tamponade, again rare. Meds like vasopressin or octreotide to constrict vessels, avoid activities that trigger vasovagal response like straining, prepare for urgent endoscopic procedures or surgery.
What kind of procedures can stop the bleeding?
Endoscopic injection of sclerotherapy, injecting a solution to scar and shrink the varices. Endoscopic variceal ligation, or putting rubber bands around the base to cut off blood flow. They clot and fall off. Shunting procedures can also divert blood flow away from the varices, things like porticaval, splenorenal, mesocaval shunts, or TIPS, transjugular intrahepatic portosystemic shunt, which is a non-surgical stent placed in the liver.
Okay, let's shift to hepatitis, another major liver condition, several types.
Hepatitis is liver inflammation. Can be caused by viruses, A, B, C, D, E, or our main ones, bacteria, meds, toxins. Goals are to rest the liver, promote healing, prevent complications.
What are the general symptoms? The chapter mentions stages, right?
Yes, often 3 stages. Preicteric, before jaundice. Flu-like symptoms, fatigue, nausea, poor appetite, maybe RUQ pain. Liver enzymes might be up. Ecteric, jaundice appears. Dark urine, clay-colored stools, itching. Some early symptoms might actually improve here. Posticteric, recovery stage. Jaundice fades, urine stool color normalizes, energy returns, liver tests improve.
Let's quickly run through the main types. Hepatitis A.
Hep A, infectious hepatitis. More common in fall, winter, crowded conditions, poor sanitation. Transmission is fecal oral route contaminated food water, person to person. Incubation 2 to 6 weeks. Infectious for a couple weeks before after jaundice. Diagnosed with blood antibody tests. Management is rest, nutrition, avoid alcohol, toxins, prevent spread.
Hepatitis B.
Hep B, HPV. Risk for those exposed to blood-body fluids, past transfusions, healthcare workers, IV drug users, transmitted like HIV. Longer incubation, 6 to 24 weeks. Infectious period can be long. Diagnosed with antigen antibody tests, management similar rest, nutrition, avoid toxins, prevent spread. Key thing. There's an effective vaccine for HPV.
Hepatitis C. Similar transmission.
Hep C, HCV, yes. Transmitted mainly through blood-body fluids like HPV. Big risk factor is IV drug use. Used to be common post-transfusion, less so now with screening. Incubation about 5 to 10 weeks. Diagnosed with antibody tests. Interventions support liver function, prevent damage spread. Big news here is highly effective antiviral treatments now available, often curative.
Hepatitis D.
Hep D, HDV, or delta hepatitis. Unique because it only infects people already infected with Hep B. It needs HBV to replicate. Transmission like HBV. Incubation 2 to 8 weeks. Diagnosed by HDV antibody tests. Management focuses on supporting the liver and dealing with a co-infection, which can be more severe.
Hepatitis E.
Hep E, HEV. More common in areas with poor sanitation like India, Mexico. Travelers can get it from contaminated food water. Fecal oral transmission, like Hep A incubation 2 to 9 weeks. Diagnosed with serological tests. Usually self-limiting, but can be very dangerous for pregnant women, especially third trimester. Management is supportive care. Good hygiene is key prevention.
The chapter gives home care instructions for hepatitis patients. Key takeaways.
Strict hand washing is number 1. Don't share personal items, towels, utensils, toothbrushes, razors. Clean shared items thoroughly. Infected persons shouldn't prepare food for others. Avoid alcohol and OTC meds like Tylenol or sedatives. Rest. Gradually increase activity. Small, frequent meals. High carb, low fat, often best. No blood donation. Casual contact, usually okay with good hygiene, but avoid close contact like kissing sex until tests clear for viruses like HPV. Carry medical alert info. Keep follow-up appointments.
Okay, moving from the liver to the pancreas. Pancreatitis, acute and chronic forms.
Pancreatitis is inflammation of the pancreas, often from autodigestion by its own enzymes. Acute comes on suddenly, usually self-limiting with care. Chronic is ongoing inflammation, destruction, scarring, permanent damage. Triggers can be trauma, alcohol, gallstones, infections, high lipids, calcium, some meds.
What does acute pancreatitis look like symptom-wise?
The nosy, severe pain, usually mid-epigastric or LUQ, often radiating to the back. Nausea, vomiting, abdominal distension, tenderness, fever, maybe jaundice. Labs show high amylase and lipase, often high WBCs, maybe high blood sugar.
How is acute pancreatitis managed? Nursing priorities.
Rest the pancreas. NPO, maybe NG suction, 5E fluids for hydration electrolytes, monitor labs closely. Pain control is huge analgesics, maybe antacids or H2 blockers. Bed rest, often semi-Fowlers. Monitor respiratory status, encourage cough, deep breathe. Absolutely avoid alcohol. Follow-up is key. Report recurring pain, jaundice, clay stools, dark urine.
How does chronic pancreatitis present differently?
Often recurring abdominal pain, tenderness, maybe LUQ mass. Key feature is staturia, fatty, foul-smelling, bulky stools due to enzyme deficiency. Significant weight loss, muscle wasting despite appetite, malabsorption. Jaundice, signs of diabetes can develop over time.
And interventions for chronic pancreatitis.
Focus on pain relief, nutrition, managing complications. Limit fat, protein, avoid heavy meals, no alcohol. May need nutritional supplements, vitamins, minerals. Pancreatic enzyme supplements taken with meals are crucial to aid digestion. If diabetes develops, need insulin or oral meds. Pain management can be tough.
Let's talk about irritable bowel syndrome, IBS. Very common, lots of different symptoms.
IBS is a functional disorder. Means symptoms like chronic recurrent diarrhea, constipation, abdominal pain, bloating, but no visible structural or biochemical cause. Cause isn't totally clear. Likely mix of environment, immune factors, genetics, hormones, stress.
How do people manage IBS?
Focus is symptom relief, quality of life. Dietary changes often help increase fiber. Drink plenty of fluids, 8-10 cups a day. Meds depend on symptoms. Antidiarrheals for diarrhea predominant. Bulk-forming laxatives or meds like lubiprostol and aquatide for constipation predominant. Sometimes allostrone for severe diarrhea predominant. Stress management is often important too.
Now, the inflammatory bowel diseases. Ulcerative colitis and Crohn's. Let's start with ulcerative colitis, UC.
UC is chronic inflammation, specifically of the large intestine, colon, and rectum. Inflammation starts in the rectum and moves upwards continuously. Causes ulcers, poor nutrient absorption. Colon gets edematous, bleeds, can even perforate. Scar tissue forms over time, losing elasticity absorption. characterized by flare-ups, exacerbations, and remissions.
What are the main symptoms during a UC flare-up?
Frequent diarrhea, often with blood, mucus, pus, abdominal pain cramping, tenesmus, feeling like you constantly need to go, rectal bleeding, weight loss, fever, vomiting, dehydration signs, anemia from blood loss.
How is UC managed, especially during flares?
Severe flares might mean NPO, IV nutrition, parenteral. Avoid irritants like caffeine, alcohol, smoking. Small, frequent meals often better. Diet during flares usually high protein, high calorie, but low fiber to minimize irritation. Avoid gas formers, milk, whole grains, nuts, raw fruits, pepper. Meds are key. Salicylates like sulfasalazine, corticosteroids, immunosuppressants, antidiarrheals.
Surgery sometimes needed.
Yes, in severe cases or with complications. Options range from minimally invasive, laparoscopic, robotic, to major surgery. RPC-IPAA involves removing colon rectum, creating an internal pouch from small intestine connected to anus, maintains continence, often 2 stages with temp ileostomy, or total proctocolectomy with permanent ileostomy if not RPC-IPAA candidate or preferred.
What's the pre- and post-op care like for these surgeries?
Pre-op. Consult enterostomal therapist for stoma placement if planned. Low-fiber diet 1-2 days before. 4V antibiotics before incision. Address body image concerns, maybe ostomate visitor. Post-op if ostomy. Pouch system over stoma. Monitor stoma closely, size, bleeding, color. Picard is good. Pale pink might mean low H&H. Cobalt black means compromised circulation. Notify provider immediately.
Okay, that's critical.
Absolutely. Monitor function, bowel sounds. Stool initially liquid, gets more solid depending on colostomy location. Crucial patient teaching on stoma care, pouch changes, irrigation if needed, specific technique, timing. Emphasize again, report purple-black stoma right away.
Now let's compare UC to Crohn's disease. Key differences.
Crohn's is also chronic inflammation, but different pattern. Can affect any part of GI tract, mouth to anus, but often terminal ileum, end of small intestine. Inflammation is patchy, skip lesions, inflamed areas separated by healthy tissue. Unlike UC's superficial inflammation, Crohn's can affect all layers of bowel wall. Leads to thickening, scarring, narrowed lumen, fistulas, abnormal tunnels, deep ulcerations, abscesses, also has remissions exacerbations.
What are typical Crohn's symptoms?
Fever, crampy colicky pain after meals, diarrhea, often semi-solid, maybe mucus pus, abdominal distension, anorexia, nausea, vomiting, weight loss, anemia, dehydration, electrolyte imbalances, malnutrition, often more severe than UC due to small bowel involvement.
How is Crohn's managed? Similar to UC.
Medical management is quite similar. Anti-inflammatories, steroids, immunosuppressants, antibiotics, nutritional support. Surgery is generally avoided if possible because Crohn's tends to recur elsewhere, even after resection. But surgery might be needed for complications like strictures or fistulas.
Okay. Let's discuss appendicitis. Acute and potentially serious.
Appendicitis. Inflammation of the appendix, that little pouch off the large intestine. Big concern is rupture, which can happen fast, leading to peritonitis, abdominal infection, and sepsis.
Telltale signs of appendicitis.
Classic is pain starting around the belly button, then moving to the RLQ, McBurney's point. Rebound tenderness, abdominal rigidity. Low-grade fever, high WBC count. Anorexia, nausea, vomiting. Patient often lies on side, knees flexed. Maybe constipation or diarrhea. Crucially, avoid heat. Laxatives, enemas can increase rupture risk.
Treatment.
NPO, semi-Fowler's position, antibiotics. Definitive treatment is apodectomy, surgical removal. If ruptured, may need drain, incision left open. Post-rupture care involves promoting drainage, positioning, dressing changes, maybe wound irrigation, NG suction, IV antibiotics, pain meds.
Moving back to the large intestine, diverticulosis and diverticulitis. Difference.
Diverticulosis is just having the pouches, diverticula, bulge out from the colon wall, usually sigmoid colon. Diverticulitis is when those pouches get inflamed or infected, often from trapped stool. Can lead to abscess, perforation, peritonitis.
Symptoms of diverticulitis.
LOQ pain often. Worse with coughing, straining. Fever, nausea, vomiting, gas, cramping, distension, tenderness. Maybe rectal mass felt. Sometimes blood in stools.
Management of diverticulitis.
Acute phase. Bed rest, NPO, or clear liquids initially. Then gradually reintroduce fiber as inflammation resolves. Antibiotics, pain meds, maybe anticholinergics. Advise avoiding lifting, straining. Monitor for complications, perforation, bleeding, fistula, abscess. Once recovered, increase fluids, 2.53 L day. Soft, high-fiber foods, whole grains. Avoid high fiber during inflammation, though. Old advice to avoid seeds nuts is less emphasized now, maybe bran or bulk laxatives. Surgery, colon resection, maybe colostomy, needed for severe complicated cases.
Lastly, hemorrhoids. Very common, often uncomfortable.
Hemorrhoids are just dilated varicose veins in the anal canal. Can be internal, external, or prolapsed, pushed out, caused by increased pressure straining with constipation, portal hypertension, pregnancy, heavy lifting, chronic diarrhea, irritation.
His symptoms.
Bright red bleeding with bowel movements is classic. Rectal pain, itching, maybe feeling a lump or swelling.
How are they managed?
Conservative measures first. Cold packs, sitz baths, warm soaks, witch hazel, topical anesthetics for pain itching. Lifestyle. High fiber diet, lots of fluids, stool softeners to prevent straining. If those don't work, medical options. Ultrasound, sclerotherapy, stapling, banding, or hemorrhoidectomy.
Surgical removal.
Post-op care after hemorrhoidectomy.
Prone or side-lying position, ice packs, monitor for urinary retention, stool softeners, fluids, fiber, limit sitting time, sitz baths several times a day for comfort and healing.
Wow, we have covered an incredible amount of ground. Disorders management, nursing care. The chapter also has summary boxes, right? Box $45 on risk factors.
Yep. It lists key risk factors for GI issues, things like food med allergies, other chronic conditions, cardiac, respiratory, endocrine, chronic alcohol use, high stress, long-term laxative or NSAID use, diabetes, family history, tobacco use, previous abdominal surgery. Good checklist to keep in mind.
In box 45-2 summarizes the common diagnostic studies. We talked through a quick reference for everything from endoscopy to stool tests.
Exactly, a handy recap of all those procedures. We also circled back to that critical thinking question about the liver biopsy and abnormal labs, stressing the need to notify the RN and provider about bleeding risk. Now let's quickly hit a few review questions from the chapter end to cement some key points. Question 466, position for colonoscopy.
Left Sims position. Helps the scope advance.
467, sequence for abdominal exam.
Inspect, then auscultate, then percuss, then palpate. Listen before you touch, basically.
468, position after liver biopsy.
Right side lying for several hours. Pressure on the site.
469, vitamin deficiency with chronic gastritis.
Vitamin B12, leading to pernicious anemia. Lack of intrinsic factor.
470, importance of early ambulation post-ab surgery.
Prevents complications like blood clots, pneumonia.
471, preventing dumping syndrome.
Limit fluids with meals. That's a key one.
472, early signs of dumping syndrome.
Weakness, dizziness, sweating, diaphoresis. Fast heart rate, tachycardia.
473, distinguishing Crohn's from UC.
Skip lesions are characteristic of Crohn's. UC is continuous.
474, position for paracentesis.
Upright helps fluid pool low down.
475, expected prescriptions for acute pancreatitis.
Antacids, cough, deep breath encouragement, maybe anticholinergics.
476, hepatitis at transmission.
Fecal oral route, hygiene is key.
477, position for enema.
Left Sims again, follows the colon's anatomy.
478, avoiding heartburn with hiatal hernia.
Don't lie down right after eating. Stay upright for a bit.
479, appearance of stoma prolapse.
Protruding, looks swollen, longer than usual.
And 480, explaining gallbladder ultrasound.
Need to lie still for short intervals during the scan for clear pictures. And that really brings us through the core content of this comprehensive GI chapter.
Absolutely. We've gone through the key nursing concepts, assessment points, procedures, safety issues, priority actions, terminology, and even the review questions. A true deep dive into the GI system based on this NCLEX-PN review chapter.
So as you continue learning, just remember how interconnected the GI system is with overall health. Understanding these fundamentals is so important for providing safe and effective nursing care.